Uh, Good morning, good afternoon, and welcome everyone. My name is Frey Hewitt. I'm the Executive Director at the International Institute for Primary Health Care in Ethiopia. So this is the first live session for the third iteration of this course. We have had the first and the second versions run before, and this is the third time we're doing this course, and we'll be discussing new issues regarding COVID-19, focusing around new surge, Delta variant, and the vaccine rollout. So just want to say welcome on behalf of the Institute, and I will hand you over to our moderator, Dr. Micah Schleif from Johns Hopkins Bloomberg School of Public Health. So over to you, Dr. Micah.
Thank you, Dr. Freyhout. Greetings, everyone. It's a pleasure to be here with you all today. I've been able to work on this course since it was first developed, and it's been really exciting to see the feedback that we've gotten and how the course has evolved and grown over the last year or so. We're very appreciative of the collaboration and all of the inputs from the Ministry of Health in Ethiopia, and for our guest speaker today, whom I think we'll all learn a great deal from. And it's my pleasure to introduce Dr. Mebratu Masebo-Cherinet, who is currently the coordinator for the COVID-19 National Response Task Force in Ethiopia, and also a senior advisor for the minister. He has more than 15 years of experience working on health systems and has previously worked on a range of topics, including facility readiness and case management, and also has some really important and valuable grassroots experience developing PHC care units and really working in a range of contexts, from the community to working on surgeries and leading at the clinical level in hospitals, and has been in charge of some of the leading hospitals and work across the country. He's also been involved as a policy advisor at the national level, and has focused on leadership skills and helping to guide the health sector in Ethiopia towards stronger emergency management and continued progress towards universal health coverage. So he's here today to share some about the different aspects of the ongoing COVID-19 response in Ethiopia, and we'll be starting off with a presentation and then engaging with you all and with our other panelists in a discussion in the second half of the session. So welcome to you, Dr. Mebratu, and over to you to say hi and then go forward with your presentation. Welcome and thank you for joining us.
Thank you so much. Thank you, Dr. Mack, and all our distinguished participants and panelists. Really, it's an honor to be with you in today's afternoon at this. It's a very shining October already passed, and we're in the start of November, with a good hope of declining pandemic, we hope. And I'm very happy to be with you. And my presentation will be very short, and I'm very open to hear your experience and questions from brothers and sisters throughout the world. Thank you so much. So, to start with my presentation, this is more about Ethiopian COVID response. So I will start with the situation that we are on, measures taken so far, and I will frankly share what our challenges are and what are our major strategies and what we are thinking the way forward. So I will mention a few priorities that we are focusing for now. when we come to global, I think as you all follow from the medias and different publications, so globally almost a quarter of a billion cases are reported, and more than 5 million deaths officially recorded. I can say it's officially recorded, but the estimate is about 15 million. So that's a big number that we lost. And also in Africa, we are reaching to 10 million, and about 218,000 deaths are already reported. So Ethiopia is the second populous country in Africa, recorded fourth biggest case in Africa, and fifth in the rank of deaths in Africa. So in our areas, like we started lab tests by sending the sample to South Africa at first, and then now currently we tested cumulatively about 3.7 million tests done. Then the PCR test was almost absent before COVID era in the country, but we started in 86 facilities, including the privates. Currently, for 7% of the tests we do are attributed to this. The positivity rate is almost an average scale. The maximum is 26, and it was in the second wave peak. So this week we are approaching about 7%. So that's almost the half of the peak that we already registered previously. Saying this, like there is also 364,000 cases reported in Ethiopia so far. We has managed, as you say from my slide, 3 waves. So the first wave is like from arrival in March to July. So it was somehow good, and we were very, very stringent on our management. Then starting from August, like it peaked, and so we faced the first wave. Then it declined immediately at October. Then it was somehow flattened to January. Then it started from January, and it was somehow protracted. So it's the longest wave we had so far. So it declined and touched at the July, in last July. Then we had another wave, which is very sharper than the previous one, as you see from the graph. Then that graph also going down. So it's not reached the pre-wave stage, but it looks like going down. So we have almost 92% of recovery rate. That's somehow good. And the moving average currently is about 450 cases in 7 days, moving average of per day. So it is somehow looks like stabilizing for this wave. Also, when we see the days, like the days we reported is obviously less than what we expect. There must be community days that we didn't report it, but we monitor the cemeteries in the country. It's not that much significant that we missed many clusters, but there probably might be much more than this number, but we reported 6,400, above 6,400. The highest number of deaths reported in the third wave. As you see, the third wave in the previous slide is somehow shorter in the curve, but the death is peaked at this wave. As you all see from the global data, Delta is attributed with third wave. So Delta is more virulent and more fatal than other variants of the COVID virus. So it's more of attributed with Delta. So we are still in the high gear of the disease we face. Case fatality is somehow less than African average, which was 2.6 in Africa. It's 1.7 in our country. Global case fatality is about 2.1. So we are under the global rate. So we have 11 regions and the 2 city administrations. Among them, there are 4 regions which are above the global case fatality rate inside the country also. So this audit is done everywhere, so we learn from our system every time. So saying this, like these are the regional contribution. So what's very much alarming is most of the diseases and the cases are attributed in capital Addis, which is almost not more than 5% of current country population, but attributed 70% of tests and 65% of death contribution. So that's a very alarming. COVID is more alarming in urban metropolitan cities than the rural areas. I will very open to discuss if this is the area that we want to engage in more. When our capacity building, like we had built 336 health facilities. These are the ad hoc facilities built through our surge capacity. Then 21,000 new bed capacity was built in these facilities. So these are converting the museums, the halls, to the treatment center. And we changed one of our iconic hall, which is Millennium in Addis, to almost a severe and critical hospital, currently working as a 51 ICU bed, which is the biggest hospital we have in the COVID facility in country. What's amazing is like the main problem we faced, there was oxygen. So we tripled our oxygen capacity throughout this pandemic. What's amazing also in our response is almost only 20% of the case are hospitalized. Others, 80% of the case, which are mild to moderate, are managed at home by our health extension and the primary health care program follow-up. So that's looks very unique for us. Like we did managed at the home level, which attributed to the great contribution of the primary health care we already established previously. Currently, there is a critical care capacity surge. We are increasing every time. Private engagement is increasing. Training we do for private and for public continuously. We enrolled the online training for more than 24,000 health professionals in the era of COVID. So we supplied equipment, and about $400 million USD was invested for equipment only in last fiscal year in Ethiopia. So when we see the age category, like most affected groups are like age less than 34, attributes about half of the cases. Then, but the days attribution is above 55 age groups, like which is only 70% in the case, but in the days it's 6-7% are attributed with this age group. And also, this is very alarming that the olds are dying in alarming rates than the others. On vaccination, I will not go to the details. We are prepared in future and our vaccination experience, but we did vaccinated about 5 million population to date, and the number of people vaccinated is like about more than 3 million. It's a very few, like Ethiopia has more than 100 million population, so we are still in the lower gear of the vaccination. The fully vaccinated groups are less than 2% of the population. So the main question comes in our area of coordination is how we could able to mobilize resources to combat the COVID response and the management of the cases. So we have a task force which is established under the Prime Minister, led by Deputy Prime Minister, and the MOH Secretary. I myself is involved in that task force, which oversees the country response. Then that is almost the strategic level. So we have at the operational level, the National Public Health Emergency Operating Center, which is still active under Ministry of Health and the Ethiopian Public Health Institute. And we have equal subnational level, which is led by regional health bureaus. Also, we have coordinating the emergency management system. We have core staff, daily morning briefs, and also we have representatives from partners on this daily morning. So we have WHO, other CDC, and other partners working day and the night with us throughout this pandemic. So we have bi-weekly strategic leadership, which is led by Her Excellency, our minister, and also we have a weekly joint streaming committee, which includes the sub-national level health leaders and the national level leaders. So that's a continuous endeavor for the last 2 years, like almost uninterrupted every week. We have prepared the emergency preparedness plan every 6 months, and we review it every 2 months to reflect current pandemic level. Also, this is the structure, as I told, it's starting from the national task force, which I led, to the emergency operating center level. So we do have stringent criteria, which includes a state of emergency previously. Then 2 directives are prepared. The first one was in last September, and the next one we did just 3 months back to review, including the vaccine and the current development in the world. So school reopening is a milestone also for us. We were closed the school even before we report the local case. Then we reopened the school with these directives that how to live with COVID. I think we are one of the early starters in the school in the continent. And we properly manage this school opening with involving the school communities. That school community includes teachers, the school principals, the parents, and also the health community. We're working almost including 1 nurse at the school also. So we try to work in the infection prevention and masking of all the schools, having just at least social distancing considered school setups and the shifting of the school to every other day. Like so we tried to that to prevent the pandemic happening in the school. So there was no report of big pandemic clusters from the school throughout the year. Also, we did the interaction review, and we did country COVID sequencing for the variants. We found all cases in this September were attributed to the Delta variant. So we responded for 3 waves, as I have shown you, and we did DHS2, which is a data tracking that we do still in individual patient level to have a country research and the data capacity as we have. We increased mechanical ventilator almost more than 300%. We did facility readiness, as I mentioned earlier. As you see from my picture, we have a bulletin, a weekly bulletin, which includes every response we do. We publish it online. We have a meeting, as I shown you, and also we have campaign digital message, which is usually focusing on social media audiences. Like we have a presence in web, in Facebook, Twitter, Telegram, which all every day we reported our cases through our minister, Her Excellency Dr. Leah. So every night we reported for the last almost 2 years through this platform. We have social mobilization campaigns, including combat campaign, which is reached every district in the country, and we were able to test 25,000 tests per day through this campaign. Then we have Mask Ethiopia campaign, which includes especially the school children and the community, and the motto of like I will not be a cause for others. So we have no mask, no service guideline, which is still we are struggling to adhere. We did also just different campaigns throughout this response. The challenges, as I earlier mentioned, and we were struggling to increase our lab test performance as expected. WHO expects 14,000 per day, but our current average is about 9 to 10K per day. So we need to increase this one also. So it's very much challenging for us. Role modeling of political leadership, media organization is different. So they take sometimes a very much enforced actions, and when their attention shifts to other priorities, like there's always, we are struggling on any areas. Competing priorities, as you may heard from Ethiopia, so there is IDPs, insecurity, another outbreaks including some cholera and other pandemic-prone diseases. So we are struggling to balance our response in these areas. Multi-sectorals, like it's a very difficult task to coordinate whole of government, whole of business, and the whole of society approach that we started at the start. In the vaccine, like vaccine equity was an issue. Like we were very much begged to have vaccine for population, but there was no vaccine around June, July. But currently we have adequate vaccine, but the risk perception is lower, and the community develops hesitancy to have this vaccine. There is also misinformation, disinformation, especially attributed with vaccine and the COVID-19, and it's more of the social media era. So we are struggling on this issue. Our strategic areas is accelerating the testing, as I mentioned, to 20K per day, revitalizing these non-pharmaceutical interventions, and integrating the COVID response with essential services. So we manage essential service in one hand, COVID in another. So we are integrating at the task force level and overseeing the two tasks together as much as we can. Then mainstreaming of COVID response to involve all sectors, and every sector is obligated to come up with its own plan how to respond to control the pandemic and support the national response. Also, we are trying to decentralize the response to the district level. We have almost more than 1,000 districts, so we are pushing to give them the ownership to respond, and with necessary logistics. Treatment expansion is there also. We are planning to integrate in 1,000 health centers to include COVID and the non-COVID services together. So in the vaccination of 20% of the population is a target for this year, and we are planning to target at least 70% of the population in 2022. So the main thing, this all should focus to build the future pandemic prepared, resilient health system that we aspire to achieve through primary health care. Finally, our top priority for the coming few months, as I mentioned, to decentralize the response to the local level, then to vaccinate all, including the school age groups. We currently authorized the vaccination of school children starting from age 12 and above. So we need to prevent schools not to become a ground for infection. So focus is on IDPs, special settings, and integrate the service with health extension workers and the family health team we have at the Warada and the Kabale level. Then we need to equip the facilities before our fourth wave comes. God forbid, we expect that wave will come maybe around February and March. So we need to prepare before that. So that's also an issue. Role modeling of political leadership, especially at the grassroots level, is very much important. So the media, the organizations, CSOs, they need to engage with us, and we are just working to engage them. So this is all of my presentation for now. If you have any questions, suggestions, I'm very much here to accept you. Thank you so much, Chair.
Thank you, Dr. Mebratu, for that very informative and sort of efficient presentation. You've covered so much ground. I think we have a bunch of questions from the participants, and we'll cover as many of them as we can, and definitely please keep them coming. Add to the Q&A, and we'll be covering a bunch of different topics. I wanted to ask you, Dr. Mebratu, if we could maybe just start kind of with the elephant in the room, which is the conflict that's going on in Ethiopia currently, and just to ask if you could expand a little bit on what impact that has had in terms of being able to do the COVID response, both at the national level as well as in some of those regions where the conflict is taking place, and if there's also some interaction between the Delta variant becoming sort of the the prevalent variant in Ethiopia and the spread of COVID because of that, and then also the conflict that's going on. If you could just comment and maybe share some of what's taking place in order to manage the COVID situation within this context. And I think you're on mute.
Okay.
There we go. Thank you.
Yeah. Thank you so much. So really, as you said, like our government and our response is like somehow multifaceted. Like we need to handle all emergencies, I think, as a center. So there is also other pandemics, and through this conflict, all obvious diarrheal diseases, nutrition, everything is at stake. So, and also the essential service compromise is also there because of the conflict, and the COVID response in this conflict area is somehow struggled a lot. So we try to revitalize it. For example, like we lost the PCR test in Tigray when it was the conflict started. So we try to compensate it with rapid test to train the staffs, and when there is no smooth relation with the government facilities, so we try to use the non-governmental organizations to involve in this task and channel our resources through this platform to involve everyone. And also we include the Red Cross organization to support us on IDP settings on infection prevention, especially. It's very difficult, like to tell you that we did a good response, but we really struggled through this conflict. So this is a big issue, especially the arrival of Delta variant complicated everything. Like we were somehow calm before Deltas, and in the middle of July, and the Delta variant came. And as I mentioned, almost we sequenced everyone, sequenced it throughout the country, like it's a representative sample, becomes Delta. So, but the good thing for Africa and for Ethiopia is, like, as you know, age dynamics. So we have most youth Belgians that gave us some room to have like mild infection and asymptomatic infection especially. So we were somehow focused on preventing the congregate setting, the targeted setting, than the general population. So then the mask campaign was reached about 80%, so 80. So that's somehow, as we witnessed throughout our scientific society, that prevents a lot, like in congregates. It's like the transportation in IDP size, and also we try to avoid gathering as much as we can, but because of the conflict, so the gatherings are here and there. So we really struggled, but we have targeted response for these centers from overall response. So we try to prioritize the pocket of these areas and try to vaccinate them. But we were not that much successful, but especially the vulnerable groups and the patients with comorbidity in these areas, in the prisons, in the areas which are somehow like we have the industrial parks, like, which employs many employees at a time. So we had 18,000 employees in one roof in one of the industrial parks. So we tried to vaccinate those all industrial parks. So we actually approached about 50% currently. So we are trying to target our responses in these special places as much as we can.
Thank you very much, Dr. Mebratu. It's certainly a very complex situation, and sounds like there's a lot of really important work going on. So thank you for explaining a little bit more about that. So we have a bunch of other questions, and we're going to focus. I want to talk a little bit about testing, and then there are several questions related to schools and children, and then I would love to ask a few questions about the vaccines as well, but we also will be having an additional live session. This is just a sort of reminder and update for all of the participants next week that will focus specifically on vaccines. So particularly if we don't get to all of the the questions today. This is something we'll pick up further again next week. So Dr. Mebratu, the next question I'd like to ask you is from another faculty member at the School of Public Health at Johns Hopkins who's joined the session, Dr. Bill Brieger, and he's asking about how primary health care is being used, and also other opportunities that you see for how it can help, particularly to increase testing and to have a continued stronger understanding of the epidemiology as that changes for COVID in Ethiopia. So if you could say a few words about, the role of both the health extension program as well as other ways that the health system is able to provide information, testing, and engage with communities as the COVID situation unfolds.
Thank you so much. Really, it's a very, very important question. I really appreciate all questions. I see some in chat, so if I try to answer as much as I can, but the primary health contribution is a very, very great, really. This is not just I'm talking in from my lips. So if you remember when the projection of the COVID arrival to Africa, so every projection in the scientific advisories we get from elsewhere is like a doom, but we tried to manage the COVID response through our existing systems. Like we all know that all systems are struggling. There is no perfect system in the world which responded for the COVID very well, but we try to balance already problematic health system that which is working in the maybe the maximum gear. So we try to balance essential service. There are double burden in Africa, in Ethiopia also. There is NCDs like non-communicable disease, which is about 45% of the population is affected in Ethiopia. And also there is communicable disease, malaria, HIV, TB, these all are there. On top of that, COVID came to the facility. So managing this at the existing facility was almost impossible. So we try to shift. We have to have temporary facilities, converting large halls to the treatment center, and we try to have supplies for this facility through global solidarity and our own active resource mobilization. We have ministerial committee involved for actively resource mobilizing from the society. So the society contributed monetarily and in the item. Most of the facilities are, by the way, established by the private citizens on their localities to take that surge. Also, we shifted the NCD care to the health centers. Like previously, the hospitals are the one which are like involved in non-communicable disease management, like diabetes, hypertension, and also we try to have telemedicine for especially TB, HIV patients who are collecting their medicine every week, so every month. So that we gave 6 months dose for them, but we put them under follow-up of the health extension program from at their home to refill and not to, as they are frustrated to get the COVID from the facility, so they interrupted. So we try to trust them through this primary healthcare program. Also, our health centers, some of the health centers are linked with the hospital. So the hospital shunts the patient to the health center to admit there, and they manage their patients as their own, included integrated with the health center. So this is the task shifting, and also we have shifted the care to the lower level to have space to occupy for the severe and the critical patients in the hospital level. So we try to hire 6,000 more health professionals in contractual base to this response, not to overwhelm existing primary healthcare program. So we moved almost 10,000 health extension workers to be trained on this COVID response, and we did have house visit through this health extension program to give to trace the patients in the follow-up, and also to elicit the symptoms early and link to the health facility to test. So we are struggling in the health center level, especially in the testing availability. So that's why we did campaign in our combat campaign, which includes the community screening and the testing at the Warada level and at the district level. So that's how we link it with the primary health care. The primary health care has a great contribution to that, note that our facilities are not overwhelmed throughout this pandemic.
Thank you so much, Dr. Mebratu, for providing that context and also really, I think, illustrating some of the important roles that both the health extension program as well as the rest of the health system have been able to do to ensure that the system is able to continue to manage and function and also deliver the services that are needed. So thank you so much. We have a couple of questions related to schools and also reaching and supporting services related to COVID for children. So maybe we can take the next question, which came up in a couple of places, which is if you could talk a little bit about how schools, how you all have been able to work with schools to sort of regulate and follow up on whether COVID-19 protocols are being followed, maybe also helping to overcome any barriers and challenges, and what you all have learned from that process so far, as well as maybe some of the outstanding things that are being worked on.
Thank you so much. Like in the school, like for us, as I mentioned, the school community comes at the first. So we are not the one really at the first hand regulating. We try to train and orient the school community, which includes the parents. There is a parent school committee which works daily in the school health. So the parents are the one which are approving the school to give. They give a license to the school to open the teaching learning process in the school. After observing all that the school is ready. Before that, like we worked for 3 months to open the schools. Especially the main challenge on our school is infrastructure. Like our schools are very narrow in the space, and the IPC materials are very shallow. Like we don't have water. Really, we are lacking the space that we can accommodate those all schools at that students at that school. So we try to have shift for every other day. So we did 3 days per week schooling at the start, not to accommodate all schools at that class. So we put 25 students maximum in one room, and that room should be a big one. So we try to have 1 meter distance at least between the school, the students. We have universal masking, like almost it was 95% in some of the schools when we measure the good practice of masking. So that is also avoided the school transmission. So still the universal masking in the school community is there. Also recently the school teachers, they came up voluntarily throughout their association to take vaccine to prevent the students, because most of the school transmission is attributed to the teacher. That the teacher is the one who speaks and who travels and who can work throughout the class. So to prevent teachers, we prioritize to vaccinate the teachers first. Then also we try to involve the community at large, like to prevent the students who are symptomatic not to go to the school. In the regulatory, like we have 1 nurses in each school recruited to monitor the students' health issue. And we have prepared 1 isolation room to put the student develop the symptoms to isolate them, and the Warada team will take from that to test that student and link with the healthcare system. So that's how we planned. We have struggled in some of the facilities, as I mentioned, through this conflict and the logistic issue, but we really managed not having the cluster of cases at the school or major pandemic spreading in the cluster in one area. We never reported that for the whole year. So we really monitor in our active surveillance system we have starting from the Warada.
Thank you very much for that explanation of all of the work that's been going on, and also the impact that it sounds like that work is having in terms of being able to continue the education process and avoid any sort of major outbreaks or challenges. So I'm sure it's been a lot of work, and it sounds like it's paying off. So thank you so much for that. I think we also have a couple of questions just looking again sort of at the district level around COVID testing and some of the strategies that you all have been using and how you've been working to overcome challenges in terms of trying to increase the sort of coverage of COVID testing. And just wanted to ask if you could share a little bit more about that.
Okay, thanks so much. So as I mentioned, we started testing COVID, sending the sample to South Africa. So we don't have, we usually never had the PCR tests for viral disease previously. So then, except the HIV tests we have, that was repurposed at first. Then we try to have aggressively the tests that in 86 laboratories, which is geographically purposely allocated to cover the geographic area that we have. And we have a sample referral process, which starts from the district level to send the sample to the nearest laboratory, and they will send through SMS and email to the district back the result, and the patient we isolate the patients before the result comes, so that the patient will be discharged if the results came up negative, or if it's positive, they will be transferred to the facility. But it takes almost an average 3 to 4 days. That's a almost a long time to know the result. Then we alternatively started the rapid test early. So this rapid test is on areas that we don't have PCR tests, and we focused on especially the symptomatic groups in the periphery. And fortunately, like most of the cases concentrated in the urban areas where we can find the tests. But in the future, we are planning to expand, as I mentioned, to 1,000 districts to have this rapid test at the health center level. Then the health extension program will refer the patient to the health center, and we are planning to have health extension kit, which includes pulse oximetry to as a barometer to know if the patient deteriorates at the local level. They will refer the patient to the health center. Then at the health center, we'll have oxygen supply equipment that will help them to start oxygenation. Then we'll have referral systems through ambulance, and that will lead to the critical care capacity that we are building in the hospital level. So these are the network that we planned and put together. It's still in the early stage. Like we are at the 30% of our plan. So we need to work to include all coming 700 facilities that we are currently planning in this year. So that's how we engage. And our plan is like replacing PCR with RDT in everywhere. Like we do it in the conferences and gatherings. So it becomes, in the future, maybe we'll have self-test which is tried in elsewhere. And we are planning to have that the community will have available at the pharmacy level and then the self-test. So to mitigate in the future. Thank you.
Thank you so much. Yeah, that sounds also like a great deal of work that's happened. And one thing that you started talking about, and I think there are also a couple of other related questions, is just how much data needs to be managed in order to do to get the test results back and refer patients and sort of keep track of everything. And then also, as you mentioned earlier in your presentation, doing a daily report. And so I wanted to ask if you could talk a little bit more about how some of these data are being managed from all of the different testing sites, and then sort of integrating into some of the other processes in the health system, and also any sort of lessons learned, challenges that you've worked to overcome in order to make those processes smooth and as rapid as possible.
Yeah, thanks so much. Like data management was one of the big tasks that we were struggling to have especially individual patient level data at the center of the response that helps us to audit the system, and also to have ongoing interaction reviews that I mentioned, so that we learn from the system as to make the decision every day. So we have established the DHS system, which is already pre-existing, but we had customized WHO tracker, DHS tracker, and with support of some partner organizations, we try to customize the tool and have a live reporting integrating every model site. It has almost 6 modules, including the point of entry, which registers the patient and they put in the isolations, and laboratory test, case management, surveillance. So these all sections are integrated in one system. That system is like reported by tablets, and also the patient follow-up, as I mentioned in the health extension workers and the family health team in the Warada, they have that tablet available for their community response previously. So we did push the application on that tablet, and that tablet started reporting. So we tried to negotiate with telecom companies to have subsidized internet capability and the 3G and the 4G. So we reported with that the live data. There was interruption backlog, but I think we try to clear that every time. So we have data task force under the national task force. One of the section is the data section. We have developers and monitoring team from most of the tough guys like we have are working on that area, because in the COVID, like external support was very minimal. So we try to move good personnel from every section headhunted and made them to work together.
Yeah, wow, thank you so much, Dr. Mebratu. That's a great overview, and it sounds like a lot of progress has been made, and you all have really set up a lot of systems, and probably as I think maybe all of us have for different projects that we're working on have had to pivot quickly to online systems, different ways of working, and so it's exciting to hear all of the work that's going on. I wanted to ask you one more question around sort of community-based interventions and some of the core preventive strategies that we know are so important for COVID and also are commonly such a challenge around the world for public health programs, which is really around sort of the non-pharmaceutical interventions, including masking and social distancing and things like that. And recognizing that there's been a lot of sort of fatigue at the community level to try to maintain those behaviors and interventions, and just wanted to hear a little bit more about what is happening in Ethiopia on that front, and what efforts are in place to try to maintain some of those behaviors, sort of revitalize any strategies and try to keep some of those things on the radar at the community level.
Yeah, thank you so much. This is a really good question and a very difficult thing that in our response we struggle to manage. We started with high intensity, like I mentioned. There was a state of emergency, which gives the law enforcement every privilege to enforce the guidelines we have. Then that state of emergency lifted after 6 months. Then we were like struggle to really enforce throughout the community. So most of the things are like just through negotiation to the community, then focusing more on providers than the personnel. Like, so you are obligated to mask up if you went to service. Like no mask, no service move was like attributed more of to the provider that like we will enforce it through. Like, for example, if you are going to banks, like you are asked to have mask before you enter to the bank. Otherwise, like the banks will be penalized. And individual behavior was a very difficult thing. So, but it evolved from more than 80% NPI, then it was going down, especially the social distancing. This went very low because we opened up business, and also the hand sanitation. Like we were very good at the first. The community said the community hand washing facility, everyone, even individual houses, they put hand washing facility around their community. They have great voluntary movement at first. Then it moved down. So currently it's around 25% the practices. Like we monitor through independent team from Black and Addis Ababa University, that is a prestige university we have. Right, so this university monitors independently in this facility. So, but this is when going down and down throughout the response. So the pandemic is going, the variants are going virulent, so our NPI enforcement becomes lower and lower. So currently in Addis, the capital, the mask practice is around 52%. But other regions is very, very low, like some of the regions below 10%, which is irrelevant for the response, so especially the public one. But indoors, the transportation, banks, health facilities, still they are greater than 70%, especially in the mask. So we really focused purposely to in the mask mandates than others. Like others are very difficult to implement in our setups. So especially no mask, no service, enforced such big facilities, especially the transmission indoor is obviously bigger than the outdoor. So we are focused in the indoor facilities to mandate. But really, we suffered a lot throughout the pandemic that the community fatigue was there.
Yeah, thank you so much. I think what you've explained aligns with a lot of experiences in other parts of the world as well. And I think it's really commendable for all of the work that is happening to try to, put structures in place to sort of monitor and, enforce some of these practices and recognizing all of the work that's been done. So we're getting close to the end of our hour. The time has flown by, and it's wonderful to have all of these questions and all of the insights from you, Dr. Mebratu. So I'd like to ask one question around vaccines, and then also recognize that we'll have another session next week. And I think there were also a few sort of more specific technical questions that we can address on the course platform sort of offline as well. I want to ask a final question, and then I'll make a brief summary, and then Dr. Freud will also say a few words about next week's live session on vaccines. So the final question for you, Dr. Mebratu, is around sort of the vaccine rollout and some of the strategies that you all have used to increase acceptance of the vaccines. I know that the vaccines that are available in Ethiopia have been expanding. The coverage of the vaccines is also expanding slowly as well. And wanted to ask you if you could just talk a little bit about what some of the strategies have been, to reach the most important groups, and also maybe a little bit to balance sort of the supply and demand, so that the vaccines that are available get used, and also are reaching those that need them. So if you could make some comments on that, that would be excellent.
Thank you so much. I can understand, like it's a big topic, so we need to feature things in our strategies and the response. But to highlight few, like we were very much struggled at first on availability of vaccine, as all other similar countries are struggled. So we prioritize the health workers at first, then the age group greater than 60 and with comorbidity 15. So we are going down and down our age eligibility criteria. And just yesterday, we decided to include the age category greater than 12 and above. So on top of that, like it was a very much like we usually have a very much great demand when there was a very great scarcity of vaccine, but that urgency like becoming lower and lower as I mentioned, the fatigue, the community fatigue, the perception, especially individual risk perception, is decreasing. So the vaccine acceptance becomes lower and lower, especially in the recent. So, but the opposite is we are having more vaccines now than the previous years. Like we were out of vaccine for 3 months, like no vaccine at all. So, but the community was urging us to have vaccine. When we have that vaccine, then the community shifted. Just they will not be, the risk perception is very much less, that they survived a year without that much significant problem. So most of they say they are okay, like with that. So some of the people, they say they are already infected and they have immune from the virus, but literally they are not. We know there are new variants. The vaccine works for Delta. We have witnessed, like we have similar this with the community in the health workers, but the health workers, especially at the first, vaccinated around more than 90% at the first. So immediately the health worker fatalities almost ceased. So we had seen the vaccine use in our society on our eyes. And so, but the community hesitancy is the biggest problem, the bigger problem currently we have. So we are working with the different stakeholders, including the religious community. So most of the reason is somehow related with risk perception and the religious thinking that the vaccines may not good thing. So we are working with the religious leaders, the community leaders, and giving awareness creations. Also, we have vaccination strategy at the static facility, going to the mass gathering, the community hub, and also going to their facility, their institution, their sectors to have the peer pressure that so that they can move together to vaccinate. So it's at the early stage, but we are trying to modify our strategy, and we are studying the hesitancy, the reason to message our risk communication and the community engagement tactics as per the recommendation that we are having. So we are in the finalizing our study throughout the community. That's how we are trying to strategize, but we are really struggling in the, I fear in the future we may struggle, but currently we have about 115,000 vaccines accepted every week in average.
Wow, thank you so much, Dr. Mebratu, for that overview. I know there's a lot more that we could talk about on this topic, and I'm looking forward to hearing more questions from the learners and from additional speakers, specifically around the vaccines next week as well. We have come to the end of our time, and I think we've covered a lot of ground, and I think it's been really inspiring and insightful to hear from you, Dr. Mebratu, about the range of work that's going on. We talked about the role of the primary healthcare system, getting some of those preventive services and information out to different groups and trying to maintain some of these important sort of preventive and awareness services and behaviors that are being implemented. We also talked a little bit about the school reopenings and how that's being managed and all of the work that's going on that front. We also talked about managing data and some of the work that's happening to ensure that the testing and referrals and everything is happening and is as efficient and timely and organized as possible. And I'm sure that's been a tremendous amount of work. And then we started to talk a bit about some of the efforts and the progress that's been happening around the vaccine rollout. So I think it's really commendable. I know there have been so many stakeholders involved and so much work from the community level all the way up to the national level and coordinating with other global partners as well. So on behalf of the course participants and panelists, I just want to say a really heartfelt thank you for spending your time answering all of these questions, bringing such an informative presentation to sort of frame some of these issues. I think that I want to hand over at the end for some closing remarks from Dr. Frehiwot, who will also say a few more words about next week's live session, which we hope that you all will also join. And of course, Dr. Mebratu, you're very welcome to join as well if you would like to and have the time. And it's just been a pleasure to facilitate this discussion and to hear more from you. So thank you so much, Dr. Mebratu.
Thank you, Maika, for facilitating and moderating this session. And thank you, Dr. Mebratu, for your wonderful presentation. And you walked us through a lot of things that has happened in parallel in terms of COVID-19 response in the country. I think we had a short time to cover a lot of things. I can tell a lot has changed, and we all have been through this pandemic for the last 2 years, and we saw how much it has evolved in terms of response, in terms of prevention and management. So there's a lot of topic to address. And I was following the chat and the Q&A session, we had a lot of questions around vaccine, which we are happy that our participants are interested to learn more about the COVID-19 vaccine, because the next session that's going to happen on November 11th is all about the vaccine distribution and rollout. And we have experts from the Ministry of Health Ethiopia, who is the director of the Maternal Child Health, Youth, Adolescent and Nutrition Directorate. And we also have another speaker from Nigeria, who's the country director for the International Vaccine Access Center, speaking about the vaccine distribution and rollout. And please park your questions if you're going to participate in the next session. And I also would like to encourage you all to take part in that session, because we'll be covering a lot of ground regarding the COVID-19 vaccine. So stay tuned. And we have Bruch, who's the guru of the learning management system. So if you have any questions related to the platform, you can also direct that question to him, and then he'll be happy to walk you through and then give you some guidance. Last, I would like to thank everyone from the Institute who participated in this, and also our colleagues from the Johns Hopkins Bloomberg School of Public Health who collaborated in this course. So thank you, everyone, and we hope to see you in the next session. And yeah, have a good day, morning, evening, and afternoon. Thank you.
Thank you.